Now I call upon Dr. Vanashree NAIR to talk about residual cylinders and higher order aberrations as a cause of unhappy IC16. Dr. Vanashree is a consultant cataract surgeon at Giridhar Eye Institute, Cochin, and a prolific surgeon. Over to you, Dr. Vanashree.
Thank you, sir. So I'm talking about residual astigmatism and higher order aberrations in a cataract surgery patient. So as we all know, now the cataract surgeries have become refractive surgeries. Patients are having higher expectations, and it's also our duty to try and give the best outcome to the patient, because that's an opportunity where we can give him a specs-free vision or probably a good unaided 6/6 vision. So understanding the ocular aberrations. So as we all know, most of the aberrations are actually the low order aberrations. 90% of them are your defocus and astigmatism. So first we need to handle those. And higher order aberrations actually make up 10% of the remaining aberrations. That is, spherical aberrations and coma are the ones which are relevant to this talk. So coming to small residual astigmatism. Now what happens is, if a patient is left with a small residual astigmatism, it causes small distortions for the unaided vision. Patient may have a good 6/6 vision with glasses, but unaided there is distortion, and that can be a reason for unhappiness. So as we all know, in astigmatism, there are three components. It's the corneal, lenticular, and the retinal. The retinal component we cannot really, change, but we can take care of the corneal and the lenticular part. Now, the lenticular astigmatism is gone once we do the cataract surgery, so we have to pay attention to the corneal aspect. And in the corneal aspect, we have to remember that it is regular and irregular. It is the regular astigmatism is what we can actually correct with our toric IOLs. So a pre-existing regular corneal astigmatism, more than 0.75 or 1 diopter, is what we can correct with the toric IOLs. And mind you, there is no contraindications to toric IOLs. So even patients with glaucoma, epiretinal membrane, macular degeneration can also benefit from toric IOLs, unlike the trifocals or other IOLs. But we have to be careful that if the cornea is irregular or the patient requires an RGP or scleral contact lenses, these patients are not good candidates for toric IOLs. So coming to the preoperative evaluation. So now we know that the corneal and the lenticular astigmatism will be present when we are checking the preoperative refraction. So that is not what we have to look at. What we have to look at is only the keratometry readings, because that is what going to matter for the corneal astigmatism. So there are two aspects: with the rule astigmatism and against the rule astigmatism. So in the older population, it is the against the rule astigmatism which is more common. That is, the steeper axis will be along 180 degrees. Another component that is important here while doing biometry is the posterior corneal astigmatism. The effect of the posterior corneal astigmatism was previously missed because only the anterior curvature was noted by the older biometers. So this effect would lead to a mean overcorrection of 0.5 diopters in the with the rule group and a mean undercorrection of 0.3 in the against the astigmatism rule. This was given by Dr. Douglas Koch. So now the newer, the modern optical biometers, they take into consideration the posterior corneal astigmatism. Lenstar actually compensates for PCA. IOLMaster 700 calculates the true PCA, and the online formulas like Barrett's universal formula and the toric calculators, they compensate for the PCA for the calculations. So coming to an example, so here if you see, the astigmatism is showing only 0.62 at 3 degrees, so you would say that it is not very significant, but if you actually compensate for the posterior corneal astigmatism, it becomes significant, and there is a 1 diopter astigmatism at the level of cornea, which will remain as a residual cylinder, so you better use a toric IOL here. This is a similar example of against the rule astigmatism, where correcting with a T2 would further reduce the cylinder to 0.13. Now, in the earlier days, it was thought that axis flip will cause a problem. So they used to leave a more residual cylinder to avoid the axis flipping. But then it was realized that flipping a small amount of cylinder is actually tolerable and preferable when treating against the rule astigmatism. But if it is a with the rule astigmatism, then you shouldn't flip the axis, because we want to leave some residual with the rule astigmatism. Target ideally should be 0.34 of residual with the rule astigmatism. The reason being, the cornea goes from with the rule to against the rule as the patient ages. So every 5 years, the cornea will change on its own. So it's better to target a 0.35 diopters of with the rule astigmatism. So try to correct astigmatism. It will give a better quality of vision to the patient, making them 6/6 happy. And with the rule astigmatism, 0.3 to 0.5, it is better to leave alone. Okay, coming to the high order aberrations, I'll quickly touch upon the high order aberrations which are practically relevant here. That is coma and most importantly, spherical aberrations in cataract surgery patients. So the aberrometry, wavefront aberrometry is actually used to know the total aberrations of the eye. And we quantify them using the Zernicke's polynomials and Fourier analysis. So how do we measure the wavefront aberrations? So they are measured at two levels. One is the cornea and the pupillary plane, and second is at the retinal level. So at the retina level, the three aspects, that is the point spread function, Strehal ratio, and modulation transfer function is what is measured. And at the cornea level, what we get is the wavefront analysis, which is quantified in terms of root mean square analysis. Now just touching upon what is point spread function. So it is the image that gets formed by the optical system of a point source of light. Now in aberration-free optics, it will form an airy pattern as you can see in this diagram. But in the eye, because of the pupil size, it affects the airy pattern. So it will form a circular image, and ideally, the ideal point spread function is measured at 6 mm. Hence, when the pupil is at 6 mm, the point spread function is measured. Strehal ratio, again, it is the ratio of the point spread function of an optical system to the ideal point spread function of an aberration-free system. So if you say that the Strehal ratio is 1, then it's a perfect optical system. 0.9 or 0.8 would be a good ratio. 0.4, 0.3 would be not so good. Now we have an instrument called the ITRIS, which actually gives us wavefront analysis, corneal topography, keratometry readings, and pupillometry. So it gives out your point spread function, Strehal ratio, and modulation transfer function in a nice way. So we can, before we put a premium IOL, we know what are we dealing with in terms of high order aberrations. Similarly, the pentacam will also give. So coming to important important higher order aberration, that is the spherical aberration, which is relevant for the cataract surgery. So what happens in the eye is, when the patient is young, the cornea is having a positive spherical aberration and the lens is on the negative side. So it compensates and there's no total spherical aberration. As the patient ages, what happens is the lens also starts developing cataract and has positive spherical aberration. That leads to a moderate amount of positive spherical aberration in the eye. Now, if we are using a standard IOL, the standard IOL has a lot of positive spherical aberration. The patient lands up with a lot of positive spherical aberration in the eye, and that gives rise to problems. So there are two lenses that we have, that is a zero spherical aberration IOL and the negative spherical aberration IOL, what we call as the aspheric IOLs. So these aspheric IOLs actually help to prevent spherical aberrations getting formed, but at the cost of depth perception, because a little amount of spherical aberration actually gives us the depth perception. So I just spoke about this. So traditional IOLs are the ones which have the positive spherical aberration, and the aspheric IOLs which we are using now, which we call as the premium IOLs, are actually divided into two, that is zero aberration and negative aberrations. So I've borrowed this from Dr. Uday Degan. He made a decision tree basically to help us understand in which kind of patient which IOL would be better. So when we have a patient who has not had any prior corneal refractive surgery and the IOL is not likely to decenter, we know that the IOL is going to remain in center, then, and the depth of field is critical to the patient, then we should go ahead with a aspheric IOL with zero spherical aberration. If the image quality is what the patient wants to be very crisp, then go with the negative spherical aberration. But if the patient has had a hyperopic LASIK, then we need to put, in hyperopic LASIK, the cornea becomes more oblate. So we need to use a IOL with a positive spherical aberration. If the patient has had a prior myopic LASIK, then we need to use an aspheric IOL with a negative spherical aberration. So just sharing some examples. So your traditional IOL would be something like a sensor, negative spherical aberrations, Acrosoft, Technis, and Vivinex, and zero spherical aberration, Bausch & Lomb, and Vista. So I already spoke about this, the cornea after refractive surgery. So just take home points. So target correction of the lower order aberrations first. Defocus and astigmatism we have to have perfected. Then focus on the higher order aberrations. Most important higher order aberration that we need to look at is the spherical aberrations. Do a tomography, find the total amount of higher order aberrations are there. If the higher order aberrations are more than 0.4 RMS, then you should avoid multifocals or the true EDOFs. Thank you for your patient listening.
Thank you, Dr. Vanashree, for that very elaborate and very descriptive talk and how